Yeah, I'm Professor Trish Greenhalgh. I work at the University of Oxford in the UK, and I trained as a GP.
Thank you. Now, would you like to, you had a very complex, comprehensive address that you gave here today. What were the main messages you were trying to get across?
Okay, well, I talked about one particular project, but actually that reflects some of the insights that I've gained from looking at many, many projects over the years. Projects where people are trying to introduce evidence-based practice, better care, higher value care through the use of a technology, so an app or a desktop piece of software or something like that. And those projects are usually less successful than their designers think they're going to be. And there's a number of reasons why that is, but in short, it's because those projects are often more complex than we think they are going to be. People think about maybe the technology, maybe the little bit of behavior change, but they don't think of all the different interacting, interdependent issues that there are when you're trying to change the way the system works by introducing a new technology.
So how do you do that without putting yourself off by having to take into account all of those things? Or do you find a different approach?
Well, I think every situation is different, so there isn't a formula for doing this. So I guess that's one of the big messages. But also, we have to embrace the complexity. We have to take account of the different interacting domains, the illness itself, the technology, what we call the value proposition. Everybody involved in this project has got to gain some value. The patient's got to gain value, the clinicians, the healthcare system, the commercial developer, etc., etc. And where we see problems is often where value is generated in one part of the system, but in another part of the system, someone's losing value, either financial value or some other kind. So that's the value proposition. Then there's all the issues around the individuals that need to adopt the technology, both the staff and the patients. People do things for, say professionals do things for reasons of clinical excellence. They want to provide excellent care. So if you're asking them to use a technology that they think is reducing the quality of care, they ain't going to do it. Then there's organizational issues. The organization may or may not be a learning organization. It may or may not have the capacity to take on innovations and evaluate their progress. And then there's wider system issues, particularly regulatory constraints. There's policy constraints. There's the extent to which organizations link up with other organizations and provide a kind of inter-organizational network. And then there's all the things that you haven't taken account of the first time you look at the problem, but they've somehow popped up over time when you go back, that because you fixed a few problems earlier in the system, and then you've got what they call emergent complexities. So that whole area is just full of different interacting complexities. So what do you do about that? Well, it's not the kind of thing where there's a simple fix, but one of the most important messages that I had today was we need to develop the capacity of individuals to make judgments and use their common sense, I suppose, to tinker with things, to adapt things locally, use imagination, use creativity, sense make, to get together and talk about the issues and muddle through with solutions. Now, these are not very formulaic and they don't sound very scientific, but actually when you're working in a complex system, they're really very important. Building relationships is another thing I talked about, that if you're a team and you like each other, you get on well, you trust each other, then yeah, when all those unexpected things happen, you can actually sit down and work through those problems, whereas if you don't like each other or if you don't really know each other, you can't do that so well.
You talked also about the power of stories, and you tell stories in your work beautifully. You gave one example here today of when you came, I think, full throttle off your bike and got treated like an elderly patient who'd had a fall because you fitted in with that kind of routine. But you said the stories have to be detailed and deep as well. How do you do that, and who are you writing for? Who are you telling those stories for?
Well, I suppose storytelling is something that comes very naturally to everybody. You know, the difference between humans and animals is that humans tell stories. So I don't buy the idea that it's difficult to tell a story. I think one of the problems is that when we are trained as scientists, as academics, we get trained out of the habit of telling stories. We get told, well, you've got to abstract, you've got to produce these things called variables and manipulate the variables and draw graphs and these diagrams all full of boxes and arrows. Actually, telling stories is much easier than that. Stories have characters, they have plot, they have unfolding action. Stories are image rich, they're emotionally laden, they're the sorts of things that really kind of hook you in. And I don't think I need to tell you how to tell a story. It's just I think you need to unlearn all that training that says no, it's unscientific. You shouldn't be telling some. No, tell it like it was. We want all the holes in it. We want the problems. We want the way people felt. We want the uncertainties. Of course, some people are better at telling stories than others, but I think we need to regain our confidence in the richly described case narrative. And in fact, my team and I have just got a grant from the Medical Research Council in the UK to look at the narrative case study as a legitimate form of research.
How has that journey been for you? You've been and are, I think, still a GP. What has led you into this level of systems change?
Well, I trained as a GP. I stopped practicing as a GP about 4 years ago now. So I'm certainly GP by identity, but I no longer see patients. What led me into academia? I never really left academia, actually. I as soon as I qualified as a doctor, maybe after a couple of years, I managed to sort of get myself back into the university environment, teaching the students. And I think that some people really get excited by research, by asking questions that nobody yet knows the answer to, and I've always just done that in parallel with my clinical work. So it wasn't a question of discovering research. It was like just not ever leaving university, which is fine.
Well, if we can apply that thinking to where we are today, and we're at the Choosing Wisely conference where they're looking at implementation and trying to scale it up, which is your big area. Yeah. What are your observations out of what you know about what's happening here and what needs to be done?
Well, interestingly, I was talking just now to, I think he's called Frank Jones, who was the president of the Royal College of GPs in Australia, and he was saying to me, it's a shame that there are so few GPs at this conference. So most of the conversations I've had, most of the examples that we've had today have been in secondary care. And yet there is plenty of room for improvement in primary care, particularly since primary care by definition is the first port of call when the patient comes along, says, I've got a bad knee, doctor, I've got a cough, doctor, I've got rectal bleeding, whatever it might be. There is huge potential for over-investigating and over-treating those patients and perhaps over-applying some formulaic approaches. So I've been very inspired by what I've seen today. I've met a lot of doctors and nurses and actually a lot of managers as well who are doing great work, but most of them are in the secondary care environment, and I agree with Frank that it would be fantastic if we could get more engagement, more involvement from the primary care sector as well.
Why would you think that they haven't jumped on board straight away? Just haven't been approached, or is there a different sort of problem there,
I'm probably the least qualified person to answer that question because I'm not part of the Australian system, but from the outside and from what I've learned, it seems to me that Australian primary health care, or certainly Australian general practice, is rather atomistic, it's rather fragmented. You've got what I would call office-based clinicians. In the UK we have, I think there is slightly more coherence to the GP sector. There's a greater sense among GPs that they should all be practicing in broadly the same way. Now, I may have that wrong, but I think there is probably a structural problem in Australian general practice. And I think Australian GPs would probably agree with me with that. That doesn't mean that justifies poor practice, but it doesn't mean it's going to be particularly hard to solve at a kind of root and branch level.
And yet you've seen those same sorts of things happen in the UK. You've seen them take them on board, the Choosing Wisely principles.
Certainly, the Choosing Wisely campaign in the Choosing Wisely movement, should I say, in the UK, I'm pretty sure was set up by GPs. Margaret McCartney, actually one of my PhD students, Julian Treadwell, was a GP in the UK and was quite pivotal, I think, in the Choosing Wisely movement. So, but then in the UK, I think there are plenty of secondary care clinicians involved as well. But then it is going to play out differently in different countries.
And just speaking of different countries, you are very active on Twitter, so we've observed you've engaged pretty much in the Brexit debate, which is still a little incomprehensible in some ways here, I think. Can you give us a sense of what you think the implications are at the moment with all of that for the UK, for health and for healthcare?
Yeah, I mean, I think Brexit is pretty incomprehensible to anyone. I'm not an expert on Brexit, but I would say it is a great example of a highly complex issue that has been oversimplified by politicians, by the press, and by the voting public, actually. They've reduced it to a sort of binary choice, all that kind of thing. Britain has been part of the European Union for 40 years, and that means that it is a Siamese twin with its European partners. You can't simply leave because you are codependent on so many different things. I think Britain isn't in a great place politically at the moment. I don't really have a lot of sympathy with the current leadership. What else to say about Brexit? Yeah, if Britain leaves the European Union without a full agreed deal, I think there is quite a lot of evidence that we're going to have big health problems. We're going to have shortages of doctors, of nurses, shortages of essential medical supplies, and the predictions suggest that there are going to be deaths, and that troubles me greatly as a clinician and as a citizen, which is why I do a lot of campaigning on social media for that cause.
And are there lessons for health professionals, advocates, etc., in something like Brexit? Should people have campaigned differently? Were the facts actually revealed? Where was the failure?
That's an interesting question. We've got at the moment Boris Johnson, who's at the moment the favourite to replace Theresa May as Prime Minister, has also been summoned to court in the UK for abuse of public office, and that just happened yesterday. Now, how that's going to play out, we don't know, but there was certainly evidence of, should we say, politicians being economical with the truth. And a couple of years ago, I was in Cape Town in another conference, appearing. Now, what was the name of it was the Global Evidence Summit, and I was appearing with some African journalists, actually, on a panel all around fake news and the whole idea of evidence-based practice in an era of fake news. And one of the things I learned from my fellow panelists is the importance of fact-checking websites. So we were talking in relation to health, and we used anti-vaccines as the example, but the idea that I can open up the Lancet or some of our medical journals and find you plenty of evidence that vaccines are a bad idea, not vaccinating one's children is usually a bad idea. But most of the lay public don't read the Lancet. So how do they interpret a claim by, for example, a politician or a leading celebrity, don't vaccinate your children? And actually these fact-checking websites, particularly in places like Africa, which are run by investigative journalists. And so what you do is you pitch them a question saying, well, look, I've heard on the TV from this celebrity that such and such is happening. And then they will go through and check the facts, and then 24 hours later you can check the website and there's an answer with a trail of where the evidence came from. And I think in an era where these claims can get put out on social media, on the mass media very, very quickly, we do need a way of checking those claims and a sort of kite-marked source of alternative interpretations. And I think we should be working actively with journalists and the press, because many of them are very responsible. We need to make sure that we're working in partnership rather than in an adversarial relationship with the press.
Fantastic. Any final words or plans for Australia, wanting tips for travelling?
Well, I'm looking forward to going off to Fiji for a holiday soon, and I'm really pleased to have survived I understand to be Melbourne's coldest day in 10 years yesterday. But being British, I didn't really notice that it was particularly cold. So.
Fantastic. Thank you very much for your time, Trish.